normal angina. We did coronary angiogram through right transradial route. We can see there is a mid RCA significant 99% stenosis. In left system we can see there is a proximal LAD having 70 to 80% stenosis, and also in the mid and distal LAD there is a significant lesion also there. We can also appreciate there is a proximal LAD lesion and also there is a distal LAD lesion. So we decided to PCI to LAD. So there are two lesions here, proximal LAD lesions and there is a distal LAD lesion. So what should be done? Should we put a long stent from proximal LAD to distal, mid and distal LAD, or we put two stents in proximally and another in distally, or anything else? So let us see what we have done. So we first pre-dilate the proximal dilation by 2 into 12 millimeter balloon. So this is the view after pre-dilation. So we first put a stent 3 into 18 millimeter stent in the proximal dilation. So this is the view after stenting in the proximal LAD. So what should be done in the distal lesion? So we decided to do plain old balloon angioplasty. Plain balloon angioplasty. That time we didn't have drug-coated balloons, so we did plain balloon angioplasty in the distal LAD lesion. 2 into 20 millimeter semi-compressed balloon inflated in up to 2 minutes. So this is the view. We can appreciate that. So proximal LAD is treated with a stent and distal LAD, mid and distal LAD treated with plain balloon angioplasty. So Mr. Chairperson, I discussed if we recall the history, Mr. Gunsley did the first angioplasty in 1977 by plain balloon angioplasty. In last case we did plain balloon angioplasty. So Bernard Courtesy mentioned that future is now. So can we call that the past is now? Once upon a time, there used to do thumb impression, our grandparents used to do, and now this same thing came in a new version, this digital version, same thumb impression. So can we comment? The past is now. So Mr. Chairperson, I will conclude here with few take-home messages. Drug-coated balloon showing promising result in PCI, especially in stenosis, small vessels, diffuse disease vessels, distal vessels and side branch. Bed preparation for drug-coated balloon should be as like as bed preparation for stenting. Plain balloon angioplasty in low resource setting still can be used, but long-term follow-up is required for those group of patients, especially the earlier Shondeep shows nice cases of DCB and nice follow-up of that group of patients. And my limitation was that I could not see the imaging of these patients. So with this, I would like to thank you for your patience here.
Thank you, Dr. Nur Alam, for your brilliant 3 cases. In your first case, you have done with DCB, excellent result. Adequate size DCB, instant stenosis, nowadays we use. But due to the lack of DCB, we can't use. In your third case, that was another case for middle lesion DCB, proximal lesion stent. You have given the stent and you have done the over to the distal lesion, went to 77 to 88, 10 years. And in the second case, you have done very nicely distally DCB and proximally stent, but you did not address the first OM, which is also critically ill, and that is a big vessel. Thank you for your brilliant cases. Thank you.
So I have one query to Dr. Nur Alam. Is there any role of IVAS or OCT to see the plaque burden in such a case? In third case, you did the plain balloon angioplasty. So plaque burden is a factor that may produce the subsequent recoil over a period of few weeks or few months. So any role of IVAS or OCT to assess the plaque burden and that can affect the recoil?
Yes, you rightly mentioned to see the plaque burden we can do imaging like IVAS or OCT that might give good result. But as there is a distal lesion, narrow vessel, less than 2 millimeter height, so we just did the balloon
In
angioplasty.
LED, whatever the size, 2.5 millimeter LED matters anyway. LED never we call it narrow vessel. LED is always the mother vessel. Lot of branches they usually provide, lot of microdam they supply. Can you comment from
Yeah, so erosion studies, erosion 1, 2, 3. Now erosion 3 has been already published. So they looked at people who come with acute MI and after ballooning by a small balloon and then do an OCT. If there is a plaque erosion, there is no need to put a stent. So younger people, even in India and Bangladesh, they come with acute MI. They are mostly in the proximal LED. It is occluded. It is predominantly, say 60 to 70% of the cases, it is a plaque erosion. All you have to do is put a wire, small balloon, aspirate, and you can do an OCT and leave it alone if it is erosion. Dr. Guzman, there is a microphone here. Yeah. So there is data to support based on imaging. You can actually avoid stenting, and you have done a terrific job in all those cases that you've seen.
I just want to make a comment. I hope so. Balloon angioplasty is something that is possible, but we do know that the restenosis is the Achilles